Sir, அதை நீங்க எனக்கு அனுப்புறீங்களா?
Okay, no problem. I'll do it. Don't worry. Otherwise, I'll do it.
Okay,
Just give
okay,
me
sir.
1 minute. Just.
Okay.
Okay. Pediatrician's prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, and amidst all people. Thank you.
Yeah, thank you, Dr. Thuru, and most respected our scientific advisor, Dr. Singarvel sir, and our ICANCL chapter chairperson, Dr. Ashok Kumar sir, South Zone VP 2024, Dr. Satish Sharma, and today's speaker, Dr. Satya, and our IAP TN&P ICANCL chapter chairperson, Dr. Aguila, and chairperson-elect Dr. Ramanathan, and Vice Chairperson Dr. Ashmi, and Dynamic Secretary Dr. Sudarsana Skanda, and Treasurer Dr. Padma Priya, Joint Secretary Dr. Suriti Ravikumar, and on behalf of IAP TN&C as well as ICANCL chapter, I welcome. And I really thankful to Dr. Thirumurugan, who is coordinating very well for this program, for making flyers and everything. And it's a really good program because the ICANCL chapter is this current scenario. It's really useful for our pediatrician to empower our knowledge as well as how to approach that if we are facing day-to-day life, what's the problem. So the child victim and mental health is today's talk. I hope that Dr. Satya and as well as our chairperson, Dr. Satish Sharma, they will give some force light, and as well as they will help us to enlighten our knowledge, and hope everybody will get more empowered after that meeting. Thank you very much.
Thank you, sir. I now request Dr. Satish Sharma to address us. Dr. Satish Sharma.
Good evening, everyone. And at the outset, I
Sir, I think your signal is patchy because you're traveling. Your voice is breaking, sir.
I think sir is lost. I think we can, once he rejoins, we can this thing ask him to talk.
Okay. Sir, shall we introduce Dr. Satya, ma'am?
Before that, shall we have a few words? I think sir has rejoined, and after that, we can have a few words from Dr. Ashok, no? Before we can.
Yes, sir. Yes, sir. Yes, sir.
It is an honor to chair today's crucial and timely session. As child victim in mental health, the missing link in follow-up. In pediatric practice, we often address the physical wound of the child, abuse, neglect, and exploit. But emotional, the silent, long, often go unrecognized and untreated. Once immediate crisis is over, care of the mental and emotional is frequently overlooked. This webinar serves as a wake-up call to integrate mental health support as a core component of the child protection and the recovery. Let's listen today our expert, Madam Satyaraj, Professor HOD, CMC Vellore, and commit to building a more trauma-informed pediatric practice because every child deserves not just to service but to heal and thrive. I think today's webinar will be very useful, and I acknowledge Dr. Ashok ji, our national chairperson of the INCALCL groups, and Madam Sudarshana, the secretary, and all the office bearer of Tamil Nadu State Branch and Tamil Nadu State IACLCL groups. And thank you very much for giving the opportunity. Thank you very much, sir.
Thank you. Thank you very much, sir. Those were very, very powerful words. May I request Dr. Ashok Kumar, National Chairperson ICANCL, to speak a few words to us, please.
Thank you, Sudarshana. I never expected to speak. Anyway, Dr. Rajendran, President, Tamil Nadu IAP, Dr. Ahila, Ayu, Chairperson of ICANCL, the Doyen of IAP, Dr. Srivastava, sir, my good colleagues. I think we are all IAP family. Shingaravelu sir, Tirumurugan, Kalpana madam. We all have a single family, so there is no need of mentioning names and all. So I'm extremely happy that my choosing Sudarshana as a torchbearer of ICANCL in Tamil Nadu is absolutely right, and she is coming up with flying colors, and I know this is going to happen. And the Tamil Nadu branch of ICANCL is getting very active. And with the help of Dr. Rajendran and his team, we will be able to do good service to our children. I think I don't want to get into the topic proper. I have two things to mention to you, especially for the leaders. We have a special general body to pass the new constitution of ICANCL on Sunday. I think all the members who are ICANCL members, please join at 4 o'clock. And we have another webinar on next Friday also at 9 o'clock on sexuality and adolescent. So I will send the link into the group, and please join. And I don't want to stand between you and Dr. Satya. And I have listened to her in Trichy. I think she was there in that meeting. I know. I think this is an area, as Dr. Satish Sharma sir said. As a pediatrician, we don't usually look at to that aspect. What is after that? And this is something which we have to in the future. And when we look at the future of our children. So this is another important topic, and I hope that it will be a very useful session. Congratulations and thank you to Sudarshana and the team, and all the best to Dr. Satya. Thank you. Thank you.
Thank you very much, Ashok, sir. May I request Dr. Singaravelu, sir, to speak a few words to us. Dr. Singaravelu, sir.
I think sir might be muted. Okay, fine. I think yeah, we can
Is Dr.
proceed now.
Ahila, madam? Ahila, madam, are you here? Ma'am, you have to unmute yourself.
Yeah. Hi,
Yeah.
everyone. Good
Hi,
evening.
ma'am.
It's a pleasure. And as Dr. Ashok Kumar sir said, Sudarshana's coming out with flying colors and always on the go and trying to make this chapter more and more active. And I think the backbone and the person behind building up this whole chapter was Dr. Rajendran, who pushed me when I said, what are we going to do? And he's been like really enthusiastic and very, very what would I say, pays a lot of importance in development of this chapter to improve the health of children. So congratulations to Dr. Rajendran, Dr. Sudarshana, Dr. Ashok Kumar sir, Dr. Satish Sharma, Dr. Singaravelu, best wishes for your presidential election, and you're going on the right track with trying to improve health of children in this country. Best wishes to all of you. And and I wish Dr. Satya all the best, and we are looking forward to listening to you. Thank you so much. Thanks. Bye.
Thank you, ma'am. Thank you, ma'am. I take great pleasure in introducing our resource person of the day, Dr. Satya Raj, Professor and Head, Child and Adolescent Psychiatry Unit, Christian Medical College, Vellore. Madam's special interests are infant mental health, childhood trauma, attachment in children, and school mental health. Madam CV is very long. I've just made it very brief. She has delivered lectures on various topics, but these are the topics I think we should ask her to address us again. Understanding childhood trauma, impact of trauma on the developing brain, oppositional defiant disorder, conduct disorder, juvenile delinquency, clinical updates in autism spectrum disorder, psychological impact of type 1 diabetes in children, approach to school refusal, therapeutic interventions in infant mental health, understanding challenging behaviors in children with neurodevelopmental disorders. Ma'am, I think looking at all this, outside of ICANCL also, I think we are going to call you for a great many topics. Over to you, ma'am. Looking forward to listening to you.
Sorry, Dr. Satya, we can't hear you. Can you hear? Is it me?
Satya, ma'am?
You hear me?
Now, yes,
Can you
ma'am.
hear me, ma'am?
Yes,
Yes, ma'am.
little bit volume is
Yes.
little bit on the
So,
lower side, ma'am.
I'd like to
Yeah, fine.
thank, is it better, ma'am?
Very clear now, ma'am.
Yeah, I'd like to thank the ICANCL and the IAP for giving me the opportunity, and Dr. Sudarshana Skanda in specific for sort of choosing me to deliver this lecture. Indeed, it's an honor to talk to pediatricians who would be able to do the most of what we are not able to do as well. So, as I always say, because most of the children, whatever their difficulties is, be it an ASD, be it a neurodevelopmental disorder or childhood trauma, abuse, neglect, present to a pediatrician more often than a child psychiatrist. So I think you are the right people. So without a lot of delay, I'm just moving on to my slides. Just give me a second. I'm trying to share my slides. Are you able to see my slides? Is that visible?
Yes, ma'am. You will have to go
Make
to
it
full
clear.
screen, ma'am.
Yeah, I'm just doing that. Right? So,
Yes, ma'am.
so child victim and mental health, the missing link and follow-up. This was the topic given to me. So I tried to be oppositional as well. I think we would have to call them as child survivors rather than victims. So these are children who have taken up a lot of courage and then being able to go through the trauma and still be very resilient. And that is the beauty of children. So I'd like to put it as child survivors and mental health, the missing link in follow-up. So if you can see here, I've tried to get paper cuttings of different things which had happened only over the last year. So it's not something which is very common only in India. Across the globe, child sexual abuse has been on the increasing trend. So be it in Pune, Bihar, you can see a few cases in Tamil Nadu. I was a part of the incident which happened by the school teachers and the PT master in Krishnagiri as well. So that's a huge number. Every month we have one big assault being reported, and it usually comes in our sort of flash for a few days and then it's gone. So how does it affect at all? I'm sure this scene is something we could have been seen sometimes. So if you take a pebble and throw it on a windshield of a car, so what happens? Not only at the site where it is hit, it is continuously the field of vision is obscured. The whole windshield is shattered. Just like that, trauma fractures a child's reality and belief system in adults. So that's exactly what happens when a child is put forth with a child sexual abuse, such traumatic events. So I'd like to take my presentation through these headings. Child sexual abuse, what is the definition? Why India? What is the burden in India? What are the psychological issues? How do they present? So that is the basic thing. So a pediatrician, pediatric surgeon gets to see the child, but after that, what? Where does the child land up? Is there follow-up? What are the specific interview techniques we can use in children? Basically, what is the effect of trauma on the growing brain? What is the long-term sequelae? So in case you don't catch them when you need to catch them, what happens? And what is the way out of this problem? So this would be the broad headings. So child sexual abuse is defined as the involvement of a child in a sexual activity which he or she does not fully comprehend, unable to give an informed consent, not developmentally prepared, and it's against the law or the social taboos of the society. So this is the brief definition given by WHO. So it can include a multiple activity. So it does not include sexual intercourse alone. Oral genital contact, fondling, exhibitionism, even exposing or forcing a child to see pornographic images can be under POCSO. So that is a very, very big step taken, and I think we need to be aware of it and ask for these things. Sexting, as we call, that is also coming under the purview of abuse. So all this has to be remembered, because not only physical harm, but there is a lot of things which causing psychological harm to the child. So what is the burden in India? Why are we so worried about it? So all of us know about 1/5 of the world's children live in India. And if you take the Indian population, 42% of them are less than 18 years of age. So that's a huge number. So as we are talking, I was just going through, every 15 minutes, there is a child who is abused, right? So by the end of the session, we have 4 or 5 children who are abused at this moment. Every second child is exposed to sexual abuse, some sort of sexual violence, and most of it is by a well-known figure, an authority figure like a teacher, a parent, or it can be a very well-known neighbor or a friend. So if you see about 42% of the Indian girls have gone through some sort of a sexual violence even before their teen ages. So that's a huge number to talk about, right? And the prevalence, if you take in boys who are in educational institutions, who are basically living in educational setups, they have a prevalence of about 5 to 57%, which is a huge range. This depends on what they define as an abuse and how they're going to take the criteria for the same. So if you see my last column, so I've put about the different forms of sexual abuse. Then this is the Government of India data as of 2007. The next one was not updated. If you take, about 70 to 80% of them have not been disclosed. And the perpetrator is usually a well-known friend, a neighbor, or someone in the relative circle. So that is something which we can easily prevent, but we have not been doing. What are the common causes? And here I'm talking about incest. What is incest? Incest is nothing but an abuse which happens in a blood relative. So usually a parent, a step happens, and a grandfather or anybody who is in blood relation to the child. So common features could be because of either alcohol abuse, overcrowding, physical proximity, or because they are isolated, or the perpetrator has a mental illness or an intellectual disability. So these could be the causes. So if you look at the different levels, what can be done? So at the individual level, there are multiple vulnerability factors for the child. Then move on to the microsystem level, where the family, where there is a poor parental control, there can be parental single parent family, there can be parental incarceration, substance abuse, mental illness, multiple other reasons where the parent is not emotionally or physically available for the child. And then moving on to the exosystem, the community, where there is multiple stressors which can be there in the environment. And of course, at the societal level, what are we looking at? Gender inequality, poverty, all these things adding on sort of feathers to the whole thing, where you can worsen the sexual abuse possibility. Despite the numbers being so high, why don't we see it so often, right? This is because children are afraid that they may not be believed. They have a sense of their guilt because they feel possibly it was my mistake that I got into this issue. Or every time they're talking about it, they're reliving the trauma. This is a concept which I'd like to explain, known as a re-traumatization. So the child is going through the same traumatic event again and again and gets even more troubled and distressed. So that is the reason why they're not talking about it. They feel they might be putting the person who's actually abusing them into trouble, because it's usually a close relative, someone very well known to them. Or it may be because of further abuse. They might have been threatened by the person who's abusing them, fear of retaliation. And last but not the least, I always tell this, and I tell it to my psychiatric colleagues, saying, like, even as parents, if we were to sort of look into it, if my child comes and tells me, I have a headache, I will definitely take her to a pediatrician, then to a neurologist, and go up the ladder as needed. But if my daughter was to come and tell me I'm anxious, do I take it that seriously at all? I would say, no, nothing. You take light, it'll be okay. You must be fine. So that is the amount of respect we give to feelings. So we respect somatic symptoms and physical symptoms, but not emotional symptoms quite a bit. And I think it's an inherent difficulty for all of us here in the country. So what are the risk factors? So usually after menarche, the risk increases. Though I must not say that in the younger age group, it doesn't happen. It definitely happens. We've had abuse as young as 2 months of age. I've seen sexual abuse. So as early as that, right? In 95% of the cases, as I said, it's a highly trusted adult who is abusing the child. Physical disabilities like deafness, blindness, intellectual disability are all risk factors for being abused. Lower socioeconomic status, absent parent, as I said, and of course, marital conflict, single parent family, many of these things can be risk factors. So what happens? This is one study. I'm sure all of you would have got your hands on this at some stage. This is called as the Adverse Childhood Experiences Study. It was by Felaty et al. I've given my references at the end of each slide. And of course, if there are anything in discussion, I'm more than happy to take it. You can see that when there is a childhood traumatic event which happens, it is just not a soft sign. It affects their disrupted neurodevelopment. It affects their social, emotional, cognitive development, leads to a lot of high-risk health behaviors, leading to comorbidity and early morbidity which can happen, and mortality. So this is one thing which I want to know, because about 19.8 years, a decrease in the life expectancy has been noted in this study. So this is a landmark study, and we now know why is it so important to look into the psychological aspects of a sexual abuse. So there are emotional symptoms. They can be behavioral symptoms. I'll be going into each cluster. So they can just present as emotional dysregulation. My child is getting very irritable, angry. She's very anxious. So she's absolutely disconnected and she's living in a different world, like a dissociative symptom, or is having a lot of self-harm behaviors or suicidal ideations. All these can be presentations. So what do I mean by this? It need not be a syndrome of depression or post-traumatic stress disorder. It can just be stress symptoms. So that can be a presenting complaint. They can be behavioral signs. A child who was dry by night can start having bedwetting again. They can have compulsive washing. They can have eating problems. It can just present as school refusal, right? There can be some traumatic play. So reenactment of the sexual behavior. For example, I had a 4-year-old child who just presented to me with emotional dysregulation, anger, irritability, and sleep disturbance. So it took me about at least 10 sessions for me to have a rapport with this child when the child was in play session repeatedly dressing and undressing a Barbie doll, right? That was when we were able to look into possibly an abuse suspicion was held. There can be sexual symptoms in older kids. There can be seductive behaviors or absolutely avoiding any sexual or lack of desire towards sexual ideas as well in adolescents. So these are the multiple cluster of symptoms we can see when a child has a sexual abuse. How does it present? As I said, there can be a lot of internalization of the abuse, like self-blame, guilt, shame, I'm not good, a lot of body image dissatisfaction, I'm dirty. So all these things can lead to a lot of dissociative symptoms. What is dissociation? It is something very traumatic for me to take and understand and accept. So I tend to almost think that, no, this has not happened to me at all. That is the simplest explanation of dissociation. Or I'm in absolute denial of what had happened, or I repress my memories just for it to resurface a few years later. So if you see, this is a cycle which very commonly is seen in children with sexual abuse. So there is a dissociation. So it's a very difficult emotion for me to deal with. So I repress it, I dissociate from the fact. And when that happens, I really don't know what happens and I'm so frustrated with myself. So to come to reality, I sort of self-harm. When I self-harm, there's a lot of shame and guilt again. And that vicious cycle continues of dissociation and fear. So unless and until you're able to deal. So what I like to impress by this is they can just present to you with single isolated symptoms, not needing to be a syndromal depressive disorder, post-traumatic stress disorder. You do not see such classical presentations and all because it depends on the cognitive level of the child when the child was abused and how the child is perceiving it, the resilience of the child, the coping of the child. So multiple things actually add on to see how a child presents after abuse, right? They can be also relationship difficulties when they're growing up into adolescents and young adults, and they can sort of be getting involved in abusive relationships because they feel that might be the norm. And of course, there are a lot of sexual difficulties as well. So when is the symptom very severe? When the duration of abuse for a long time, greater frequency of abuse, when there was a forceful penetration maybe, when it was perpetuated by a father or a stepfather, a very close blood relative otherwise, when there's significant family dysfunction, and even lack of maternal support, when the mother is dismissive of the child's claims, that can add to the distress. So two things which I'd like to sort of explain is one is the intrafamilial abuse, where it is between one close relative. So they go through clearly 5 stages. So how does this happen? It happens first where there's an engagement phase. The perpetrator will basically induce the child into a very special relationship with them. And then there is a sexual interaction phase, which will just start from petting to kissing and then moving on to more intrusive forms of abuse. Then goes through a secrecy phase where the perpetrator continues to sort of threaten the victim not to sort of disclose the abuse. Finally, either it's accidentally revealed or the child discloses. And then the child feels, oh my God, what I did was possibly wrong. I must not be telling it. I'm going to be judged about it. And there is a suppression phase. So this happens in most of the intrafamilial abuse. Extrafamilial abuse, it's usually one single instant, someone abducting the child, a stranger may be abusing the child, or it can be like a pedophilic perpetrator who grooms children over a period of time to have sexual favors, right? All of us are aware of a solo sex ring where there's one sexual abuser or perpetrator, and then there is a multiple children who are victims. So we have to be very careful in identifying these rings as well so that we can help. I'm not going to the detail of this, basically evaluation. So what happens when there is an abuse, right? The medical evaluation happens, right? So we take a swab, we try to see if there's a vaginal tear that's done by a pediatric surgeon. Pediatricians do all the bloodborne viruses screening and all those things. All that is taken care of immediately in case there has to be emergency contraception. That's done. Everything is taken care of. The forensic part of it happens by default because the police are involved. So what doesn't happen? That is where the missing link is. What doesn't happen is a therapeutic evaluation of the child. So you need to look into the psychological aspects, the strength and weakness of the child, make a treatment plan which is very specific to the child, and basically your first few interviews are going to be the foundation stones for you to be able to relate to the child and continue the psychotherapeutic input as well. So you have to have parent interviews, which can be in an adolescent after seeing the adolescent, and in a child, you see the parent with the child, or if the child is comfortable to be seen first, then that can be done as well. You need to get it from a multiple source information because if the parent was a perpetrator, then you might not get the correct histories. You're going to get very inaccurate histories. So we need to be mindful of that. Symptoms can, as I said, can be isolated symptoms or just behavioral changes. So don't look for only depression or anxiety disorder or PTSD needs to go to a child psychiatrist. No. Even if there are behavioral symptoms, please refer them to a child psychiatrist so that we would be able to intervene early and do the needful for the child. I'm sure I need not be talking about this to pediatricians. You have a very good gift of the gab and you'll be able to do very good interviews with the children. Specifically, if you take child sexual abuse, only a few things to remember. Let's not make an intern see the child first, then an SR, then a resident, then of course a consultant. So not having that hierarchy. So to have minimum number of interviews, just like a one-stop center, if they can be a one-way mirror room where a psychiatrist, a pediatrician, a pediatric surgeon, a social worker, and a legal person or a forensic person is there on the other side of the one-way mirror room, and we're able to get the details, I think that's the best way to go about it. If possible, do audio tape or videotape so that it need not be repeated in front of the judge or the attorney. Use restatement, avoid direct questioning, avoid repetitive questioning. What happened? So interrogation is not the duty of a psychiatrist or a pediatrician as well. So when there is an index of suspicion, it's our duty to report because it's mandatory reporting, but I feel it is the burden on the judicial system to see whether it's happened or not. Somehow I get a lot of consults to say, can you please talk to the child and ask actually what happened? And I keep telling them back, that's not my job. I'm not going to traumatize the child even further. So having an awareness of that is very essential. So repeated questioning must be avoided. Usually have the caregiver with whom the child is very comfortable in your confidence. If there are police involved, they must be in a casual dress. Look into the child's both verbal and non-verbal communication and reciprocate it the same way. Definitely no threat, no undue pressure. Just because we want to elicit the trauma history, it doesn't happen. I always say this statement, it is very easy to take a child out of a trauma, but to take the trauma out of the child may take years together. So we definitely must be very mindful of that. And just because we have a clinical interview doesn't mean the child is going to disclose everything in the first interview. Multiple techniques can be used, projective techniques can be used, play can be used, squiggle game can be used, interactive play sessions, verbal projective techniques like 3 wishes, what would you like to have, or a desert island, who would you like to take? So then the child would come up with the underlying wishes or thoughts the child has, and you're able to interpret as to how we can go about and elicit the traumatic history. So finally, when you're taking of an adolescent, definitely be even more careful because they can get very defensive at times because they feel very embarrassed or they feel they're judgmental and they might not open up at all. So definitely showing a genuine empathy in what they've been through is the best way to get to an adolescent, to be able to relate to them so that they can explain. Re-traumatization was a concept I had explained earlier. So this is reliving a traumatic event which has happened in the past. That is all it is. So anything can be a trigger. For example, the place, the perfume the child had felt when that happened, incident happened, the color of the shirt or whatever it is, that might trigger. So anything can trigger a traumatic experience in a child. So being very sensitive is essential. Otherwise, the child is going through another trauma, which is going to be equally difficult for the child to manage. So I have now impressed to say why we must refer. So what happens if we don't refer? What happens if they're not identified, if they're not diagnosed? The medical part is taken care of, the forensic evaluation happens. So what? So usually after about 10 years, they usually resurface in many of these as runaways, as delinquents, or as prostituted children. So this is the amount of burden the child can go through. So being very sensitive to the long-term effects is essential. And I don't think I need to impress a lot about this to the pediatricians because you all know how much a trauma or a arousal state can happen. It activates the sympathetic nervous system, the HPA axis is activated. It has significant adverse effects on the brain. Decreased brain volume in the corpus callosum. MRI scans have showed that very small prefrontal cortex. That is why they can't think, they can't regulate their emotions. They are very impulsive. So past history of trauma can affect even the electrical activity in the brain metabolism, and they're unable to even integrate complex information because of this difficulty. So it has it's a very nice book called as The Body Keeps the Score. So after an abuse, it's definitely not the acute injury, So that would heal. But what is going to be sort of causing the scar is what is more important. And the behavioral and emotional changes. So they can absolutely not talk about it and have a lot of internalizing symptoms, just keeping it to them into themselves. Their scholastic performance might decrease significantly because of a defect in the executive functioning. That is because of your prefrontal cortex. They can have hyperarousal and startle response. So even if a door slams, they will jump out of their skin. That can happen. And of course, they have a lot of difficulty in social interactions after that. And as I said, disrupt neurodevelopment, social, emotional, cognitive delay can happen. So we always talk about HIE sequelae and hypoxia early in the perinatal period as causes for neurodevelopmental disorders. Definitely, this can also affect the child during the early neurodevelopmental period. So we need to be very mindful of that. Trauma affects your emotions. It can basically disrupt the child's capacity to organize their internal emotional domain. They can't regulate their emotions. They feel dysregulated most of the time, and therefore they can't manage their emotions. You can see that the developing brain, so the first 3 years, so I'm sure all the pediatricians know about the importance of the first 1,000 days. So you have taught the world what the first 1,000 days is about. So any developmental trauma in this early period can cause significant difficulties on the brain organization of the neuronal structures. So definitely this has a lifelong impairment and therefore very, very crucial to sort of catch the children early. In a relational context, if you take, when a child is in a very safe environment with familiar people, the child feels very calm, less anxious, well regulated, stress free environment. But if you take, it's a very hostile environment, they are very unfamiliar, they don't know the caregiver, that is when the stress responses get easily triggered and you're not able to control it. So if you can see, this is from the Australian guidelines as well. Trauma affects everything. So starting from behavior, the brain, the body, memory, relationships, emotions, learning, neural development, you name it, and trauma has already affected and disrupted it. So this is why I said it's like the pebble which is breaking a windshield. It absolutely shatters the child's future later. And when it is happening in the critical period of development, definitely they are more vulnerable to any environmental change, definitely more so a traumatic experience. So trauma also affects learning. So as the frequency of the trauma increases, the memory declines. So be it a narrative memory, be it episodic memory, or be it working memory, all these are said to be affected, and therefore trauma affects learning as well. All of us know about POXO, so I'm not going into the details. So it is mandatory reporting as of now for any of the medical professionals and a responsible adult in the community as well. So we definitely need to be on board to be able to identify and help children as well. So there are multiple ways in which all of us know definitely prevention is better than cure. So how can you prevent? Promoting a very healthy development in the child, nurturing secure attachment with the primary caregiver. So even when the child is feeling uncomfortable with an uncle or a neighbor or a friend who comes home, the child is able to open up and tell the parent before something actually happens. So able to open the channels of communication with your child or adolescent is absolutely essential. Social and emotional competence for children, what is right, what is wrong, when can you express yourself, how can you express your emotions? I think working on that is very, very essential. Working on parental resilience and giving them a support group. So basically telling them that don't worry, you're not alone in this war. You're not alone in this battle. You have many more people fighting this battle and we are here to do it with you. I think that is what is needed for a child survivor. With the child, work on good touch, bad touch. I'm sure we do it now regularly with all our children who come to our OPD for even different conditions. We can have it in our OPD rooms as pictures, or you can have, when you have a waiting room and you have a TV playing on, you can have these screenshots being played so that parents are aware of what is happening. And the no-go tell is some very good strategy again, which you can display in your office rooms. You can show them that shout in a loud voice, no, move out of the place, go to a safe place, and then go to a safe adult who you can tell or who you can talk to. This can be done at the school level, at all our clinics, when we see children. I think in any place where there is children, and I don't think there is any place where children are not going. So everywhere and anywhere, I think these display boards must be put so that children feel empowered as well. Unfortunately, if the event has happened and the child has gone through a traumatic event, definitely establishing a sense of safety and security is essential. Only then will the child open up and divulge the information to you. The child is going to share what happened, what was the traumatic event, how they feel. At that time, establish a therapeutic alliance with the child, allow them to show their anger, express their anger, and then deal with them. Don't show sympathy, show empathy. So what is empathy? Telling them, I understand how you feel, rather than saying, oh my God, it must have been terrible for you. I really feel sad for you. I feel sorry for you. So these are, in fact, can be counterproductive as well. I understand you've been through a difficult situation, but we are here to manage it with you. So strengthen your child, build the resilience, empower them. That is what is very essential to be done. Last but not the least, I'm sure when you're referring to a child psychiatrist, they go through steps, and trauma-focused CBT is what we do for children and adolescents. So adolescents definitely yes, but children, play therapy would be used for the younger group depending on the developmental age of the child. And if it is an older child where the cognitive behavioral therapy can be followed, definitely we'll go through trauma-focused CBT, where there's relaxation, effective expression, giving them the opportunity to narrate the trauma. So that can be either in the form of pictures, in the form of stories, or in the form of puppets. They can use any medium for expression. And of course, then finally end up with conjoined sessions and ensure future safety of the child as well. So these are my references for my session today. And thanks a lot for your patient listening. Just like to end by saying our eyes usually don't see what the mind does not know. So let's keep our minds open, identify, know what's the missing link, and try to fit it. Thank you so much for your patient listening. Thanks.
Thank you, ma'am. Thank you so much. That was, I think that can be called an oration. That was absolutely wonderful. You took us through how to suspect abuse and how to handle a child. And when he or she comes as a victim, you send them out as survivors. That is our job. So you delineated what our job is and what the job is of the judiciary. And the mental wellness of the child is always lost in long-term follow-up. In any busy pediatric OPD, we think when we look at the body and we have healed the body and case closed, we have done our job, especially after documenting everything. But like you say, the trauma never leaves the child. And God knows how many such children are out there, and we have not reached out to them. Thank you so much, ma'am. We will be bothering you more and more in the coming months. That was an absolutely wonderful session.
Thank you so much.
Thank you. Satish
Any
sir.
questions, anything, I'm more than happy to take.
Good evening, ma'am.
Good evening, ma'am.
Thank you so much. That was a really enlightening session as always. And correcting us from talking a child victim to child survivor is something I learned today. And thank you so much. I just have two queries, ma'am.
Yes, ma'am.
One is this safe touch and unsafe touch. Because it is being taught at school from an early age onwards, and also parents, as parents, we also tell children from early age. Sometimes parents, mothers come and tell us that the girl is not allowing even her father to give bath, and she is not allowing any of the close family members also to carry her and all that. How to go about it, ma'am? Are we overdoing it from early age, or what is the right age to introduce?
So thanks a lot for that. So usually, as we say, when does the concept of gender role, gender identity, so when they're able to identify themselves as a boy or a girl, say 3.5, when the cognitive maturity comes, I'm sure we need not emphasize about the abuse, but definitely good touch and bad touch can start. Right? This is again one of the myths, like usually even psychiatrists, when they feel like, oh my God, I must not ask a person or a child who's depressed, are you having thoughts of any self-harm or suicide? Because we feel that is going to actually increase the risk of suicide, isn't it? But that doesn't happen. Actually, it gives them a forum to talk about it, and therefore there can be a decreased risk, but definitely no risk is elevated. Just like that, I think this is also a myth. So there is nothing like safe areas for touch or good touch or bad touch. So usually you say anything which you're uncomfortable with. So that is an easier, rather than showing the traffic light signal picture for a younger kid. You must tell the child it is good whenever you feel good about something, you're comfortable with something. Children are very, very shrewd to understand this, right? So when something is not okay, when you feel uncomfortable if someone is touching you, don't hesitate to ask for help. And I don't think, because as I said, the burden is almost every alternate child. So I don't think we are wrong or overdoing something in sort of helping our children understand what is good, what is safe, and what is unsafe touch. I think we just need to be a little more gentle, and maybe it is a parent's anxiety as well. Should I tell my child all this? Am I sort of unnecessarily giving information so that the child is going to learn something? Not at all. I always feel nowadays what happens is children have access to much more than what we did. So they actually learn from different sources. Before, I think, when possibly in grade 7 or grade 8, when the reproductive system was there, that's when we used to first look at it with awe. Now it doesn't happen. You have everything almost on social media, on TVs, on screen. So rather than they getting a misinformation from some other place, I think it is good for us as parents or as doctors, their family pediatricians, to tell them and convince them and allay their anxieties to address the child. Hope that answered your question, ma'am.
Yes, ma'am. Yes, ma'am. Very
Thank you so
clear.
much.
Thank you.
Thanks a lot.
And the second query is, recently I had a girl of 7 years. She was abused physically by a 12-year-old boy in the hostel in an international school in Ooty. So when this happened repeatedly, and even after telling the teachers and warden by the girl, nothing was no action was taken. And the mother was also not informed, but the girl had been complaining to the mother over the phone about abdominal pain, somatic symptom was there. And finally, I think the girl's friend, who is 2 years senior to her, conveyed that possibly your daughter is abused. This is what the mother came to know. And then they came to the clinic straight from there without, the mother didn't talk to the child. They just rushed to the clinic, and it was a busy day. In that situation, how do we take such children, ma'am? Because we will not be able to do justice to the child. But at the same time, when both of them are traumatized, we can't say no and send them off. So how do we approach?
Very true, ma'am. Like there are a lot of gray areas in this. So if the perpetrator is an adult, it's clearly coming under POCSO, no doubt at all, right? And if the age difference, unfortunately, the age difference, because sometimes such children get also away with calling it as sexual explorative play. And then it's not so. One is the legal part of it. Do you have to report it? Not report it. That is one question. So usually what we do in such cases, when there is a gray area, when there is a doubt, we have a team. So here in CMC, we have a POCSO team. So I'm the vice chair of the team. So we have our medical superintendent, myself, we have child psychiatrists, pediatricians, pediatric surgeons, obstetricians, and we have a forensic person all on the team. So we have a case discussion where it's presented, and then we sort of vet it so that we know whether we need to proceed legally or not. That's one thing. Because in India, those norms are not very clearly delineated. That's one thing. Coming to our clinical question, which is what is more important for us. So in a busy OPD, yes, it is very, very difficult to sort of see, because when we start seeing a case, ma'am, it takes at least 2 hours, 2.5 hours. And I'm sure for you to have that amount of time is absolutely not possible in your place where you're seeing 40, 50 children in over, say, 3 hours or so. So the best one thing I have found is take the parent and the child into confidence and ask them to come on a lean day where you're able to spend time with the child. Because if we are just going to sort of deal with it very superficially and leave it, then possibly the child's needs never gets addressed. So I would say, like, yes, this is very important. So we look into the abdominal pain now. So this can be possible causes. But then I'd like to talk to you a little more also. And then try to see that you're able to get to them to another appointment where you would be a little sort of free so that you can spend, say, half an hour or 40 minutes with the child and the parent to try to convince. So this is one thing which I usually try. And definitely reporting on the first instance, ma'am, though it is mandatory reporting, we found it very difficult practically because I do a mandatory reporting and the child doesn't get back to me. So what have I done finally? So I've not given the clinical care I'm ought to give. I've sort of sent the family and the child off. So sometimes it's like a catch-20 situation. So unless and until I'm able to establish a rapport, maybe the first meeting, second meeting, third, till then I do sort of keep it and then report it so that we will be able to take the family into confidence. And I do a few things. I will say that if you're not keen to sort of proceed with it legally, fine, we can mention that and give the number of the father, or so that the child is not exposed to any sort of harassment by the legal system as well. Because legal system coming in questioning is again another re-traumatization for the child. So clinically, we are not doing any help. So if possible, that can also be done, ma'am. So clinically, I would say take multiple sessions to sort of prime the child and the parent and then sort of disclose about what we're going to be doing.
Okay, ma'am. Thank you.
Ma'am. Thanks a lot. Thank you.
Ma'am, I have one question.
Yeah, please, ma'am.
A child victim, perpetrator was a relative. FIR was filed. The mother was very much strongly in favor of getting justice. By the time the case came for hearing, the child had grown out of the trauma. She was going to school. She was, within brackets, normal. She had completely forgotten and she was absolutely okay. So this time the mother said, why do I have to go? Why do I have to go to court? My daughter's, she's come out of all this. And now they want her to go back and tell about what happened to her. Why should she be subjected to all this? It is okay if I don't get justice. I just want my daughter to be happy. I could not tell her anything at that time, ma'am. I felt in a way she was probably right, that our system was wrong. What would we advise in such situations, ma'am?
It's again a very, very tricky situation, because one way, if you're taking it from a legal standpoint, it's like it has to be done, because you don't know whether this child is the only child the person has abused or there are multiple people. So if you look at the larger societal well-being and not only my child, then definitely by default, it's better that the person gets a verdict and gets a sort of sentence for whatever he has done, for the crime committed. But taking into account the child and the clinical perspective of it, then I definitely think it's a very, very difficult situation. But I would frame to the mother like this. So it's nice that your child was resilient enough to sort of come out of the trauma. But What would give her more of a solace is when she knows that the trauma, see, all of us need closure. Closure is usually, how do I say, we use the term of closure in grief. So, for example, we have a lot of rituals, isn't it, when a person dies? So that is for us to have a closure to the grief and move on with something. We sort of internalize the person who's dead and then we move on with our life. Something like that. If this the case is not closed or the system is there, there's no closure to it. But if the closure happens, they feel a little more sort of confident and less anxious later on. There are studies which have sort of proved that as well. So maybe that is something you can quote. And you can tell the child that there will not be a direct questioning and that it can be done only with the judge so that the child is not re-traumatized as well. So these are the three explanations we can give to try to convince them. And as you rightly said, at the end of the day, we can do our best, but then it's the choice of the parent and the child to go or not go. But these are the standpoints which we can give them to help them make a decision or facilitate the process.
Thank you, ma'am.
Sure.
May I, Sudarshana? Can I have
Yes,
a
ma'am.
moment? Yeah.
Please, ma'am.
Thank you very much. Thank you very much, Dr. Satya. That was a really informative session. Two things. What Dr. Jayashri said, I think it's a real problem. Fathers really are very distressed that they cannot even hold their children's hands, daughters' hands, hug them. So maybe because these children are taught about good touch, bad touch from school. I think the first information about this comes from the school. So maybe the teachers do not have the kind of language to make these children
Very true,
understand
ma'am.
that it is okay. So I think that is one issue. And the other thing that I would suggest is, I think in all these sessions, by default, I think we should talk about self-defense. We hardly talk about self-defense in any of these academic sessions, whether it is right to talk about the right to have self-defense techniques for girls, boys
Definitely,
also.
ma'am. Definitely, yes. As you rightly said, girls, because boys more, ma'am, because actually most of the data shows that abuse is slightly higher in boys. So definitely, yes, telling them, teaching them, and empowering them, not only mentally and psychologically, but also physically being able to defend themselves is something we must do. Definitely needs to be done, ma'am. That's a very valid point.
Thank you, ma'am.
Thank you.
Do we have any more questions coming up for ma'am?
Madam, I have one general question.
Yes.
In your from your statistics in CMC Vellore, really how much of the what is the percentage of the perpetrators of this crime are really punished? Do you have any statistics on this, madam? Because
I don't have a publication write-off, sir, like to say that this many cases we have filed and so many, but I have attended at least, how should I say, about in the recent past year, about 4 or 5, and all of them were actually convicted, sir. So
great.
actually that gives a lot of, how should I say, it was a very traumatic even for me, sir, to be there because there was one 3 children being abused by father, Chittappa, and the paternal grandmother, Pati. So all of them, that was a close-knit family. They were in the Gulf. And then they were basically from Vellore, but then resettled there. So when that case came up for hearing, actually, we are supposed to be expert witness. So it was supposed to be like what our thoughts were. So I thought it's going to be over in 5 to 10 minutes. I was actually cross-examined for 2.5 hours. And the person was like, he had brought Oxford textbook of psychiatry, childhood trauma. He showed me all that and he said, have you seen? And I'm like, sir, this is the first time you're seeing the book. This is like my Bhagavad Gita and Ramayana. This is where I sort of do my job. So the reason is it's really nice to know that, yes, now they are very, very proactive, sir. And most of these children who I'm talking about, it's like a fast track. It's been only 4-5 months since the cases have come. So very recently, I'm now seeing this trend that they're really on it and they are being convicted as well. So that's something very positive. That gives us some sense of hope, sir. Thank you
Because
so
of
much for your...
all the hard work you are doing and documentation you are doing,
Yes, sir.
really want to know how much of them are really convicted, or because many use the influence and power and political thing to come out of it easily. We
Sir,
have been seen one incident from here and from Trichy. Hope you are
yes,
aware
sir.
of it. So that's
I know,
not
sir.
a good
Yeah,
question.
I
Yes,
know.
yes, madam.
So as I said, sir, so
Mm.
you always look at the half full, half empty. So I'm
Yes,
looking
madam.
at the positive things, and that motivates us. You're perfect in saying that, sir. So there are many slips between the cup and the lip. I think there are many cases which have not got justice as well.
Yes.
So that is definitely there. But
Okay.
these are a few positive cases. Give us some motivation, sir.
Yes. Your presentation was excellent, madam. It was
Thank you
nice.
very much, sir. Thank you
Very
very
useful,
much.
madam.
Thanks for your time.
Thank you.
Thank you,
Thank you.
sir.
Thank you.
Do we have any more discussions with ma'am? Satish Sharma, sir. Satish Sharma, sir, are you there?
I think he is gone. I think
Yeah.
see, very often other meetings, by the time the speaker finishes, everybody just runs away.
Sir will
But
have...
I still find that nobody is going actually.
Ahila madam.
So thank you.
Ahila madam irkangla.
I think if there are no comments, then I think if there are no questions, we can probably end the
Okay,
meeting.
okay.
Thank you very much.
My sincere, on behalf of IAP TN&C, Satyaraj ma'am, we thank you from the bottom of our hearts for enlightening us on such a challenging topic. And we have just realized that we have so much more to learn. And it takes a lot of courage to face a child who has undergone such an experience. And we feel that the child's difficulty is so much more compared to our challenge of taking that history, documenting, and talking to the family. Thank you very much, ma'am. Sincere thanks to our chairperson, Satish Sharma sir. Many thanks to Rajendran sir for forming this group. It was because of him that this group was formed, and sincerely hope that we continue having many more such sessions. And dream is that every pediatrician should be POXO aware in Tamil Nadu and Pondicherry. That is the dream. So no child should ever be missed, and every child should get full justice through us. Many thanks to Singaravelu sir. Tirumurugan sir, thank you for putting up with all my messages and phone calls and for helping me with all the troubleshooting.
I'm part of this movement, so don't alienate me.
You are part of the movement. I'm not alienating you, but I keep calling you. That's why. Thank you for being available. Ahila madam, thank you. Ramanathan sir, thank you. Thanks to all of our EB members, and thanks to all members who have stayed on till now to listen. And we will have many more such sessions involving Satyaraj ma'am also. Thank you very much.
Thank you very much for the opportunity, and it's really heartwarming to see so many pediatricians who are so busy on a weekend to be logged in. So thank you so much. It's an honor for me as well. Thank you so much.
Thank you,
Have a
ma'am.
lovely weekend. Bye-bye.
Thank you very much.
Thank you so much, ma'am.
Good night.
Good night.
Good night.